Most advanced diseases eventually stop responding to traditional androgen deprivation therapy and thus are categorized as castration-resistant or castration-recurrent prostate cancers. Imaging tests may be required to monitor for signs of distant metastasis. Factors affecting the frequency of imaging include age, overall patient health, PSA velocity, and Gleason's grade. Patients who develop CRPC should be continued on ADT with an LHRH agonist or antagonist to maintain the castration levels of testosterone. Uh, this is the workup for patients of non-metastatic castration-resistant prostate cancers. If studies in CRPC, if studies are negative for distant metastasis, ADT should be continued and PSA doubling time should be checked. If PSA doubling time is more than 10 months, then patient should be kept on monitoring or other secondary hormonal therapies can be used. If PSA doubling time is less than 10 months, then preferred regimens include apalutamide, darolutamide, and enzalutamide. And periodic PSA testing and imaging should be done. If PSA is increasing trend, then imaging should be done, and it can be either M0 or could evolve into metastatic prostate cancer. If PSA is stable and there is no evidence, then same treatment should be continued. In patients with metastatic CRPC, biopsy should be taken from the metastatic lesion to check for certain mutations like microsatellite instability, homologous recombination repair, so that certain drugs could be used. ADT is continued, and additional treatment options include bone resorptive therapies, palliative radiotherapy, and best supportive care. In adenocarcinoma of CA prostate, patient has received no prior docetaxel or any hormonal therapy, then preferable agents include abiraterone, docetaxel, and enzalutamide. If patient has progression on prior novel hormonal therapy, but he hasn't got any docetaxel, then we can add the docetaxel, and if he has a BRCA mutation, then the olaparib can be used. For patients with progression on prior docetaxel but no hormonal therapy, then agents include abiraterone, cabazitaxel, and enzalutamide. If patient is on prior docetaxel as well as novel hormonal therapy, then cabazitaxel and docetaxel rechallenge can be used. Treatment options for metastatic treatment options for castration-resistant prostate cancer include chemotherapeutic agents like docetaxel, cabazitaxel, next-generation hormonal therapy, immunotherapy, radiopharmaceuticals. Docetaxel acts by inducing apoptosis in cancer cells through T53 independent mechanisms. Toxicity includes hematological events, nausea, vomiting, fatigue, nail changes, hyperlacrimation, diarrhea, neuropathy. There was a text 327 trial in which patients were included. There were 3 arms in which one arm was 3-week docetaxel group, weekly docetaxel group, and mitoxantrone. 3-weekly docetaxel group showed highest overall survival rate of 18.9 months. The Southwest Oncology Group also conducted a trial in which 770 patients were included with progressive CRPC. Docetaxel versus mitoxantrone were there, and median overall survival was higher in docetaxel arm. Cabazitaxel is a second-generation taxane agent used for treatment of docetaxel pre-treated metastatic CRPC. Dose is 25 mg per meter square IV every 3 weekly. Adverse events include neutropenia, diarrhea, and peripheral neuropathy. Tropic trial was there to study mitoxantrone versus cabazitaxel. Mitoxantrone had increased overall survival rate, increased progression-free survival, time to PSA progression was also increased, and PSA response rates were also increased. Hormonal agents include abiraterone. Abiraterone is a CYP17 inhibitor. It inhibits 17 alpha hydroxylase and C17 and 20 lyase, thus reducing the testosterone levels, and also aldosterone levels. It increases the ACTH levels. Thus, it includes side effects include hypokalemia, hypertension, fluid overload. Dose is 100 mg per day. Should be given along with prednisolone. COUA 301 trial. It was conducted in men with docetaxel pre-treated metastatic CRPC. The radiographic progression-free survival was increased in abiraterone arm as compared to placebo, and overall survival was also increased. Enzalutamide acts by inhibiting the nuclear translocation and DNA binding. It is effective in CRPC patients. Side effects include fatigue, diarrhea, hot flashes, and seizures. Its efficacy is as equal as abiraterone, and dose is 160 mg per day. A firm study was done in which patients who were pre-treated with docetaxels were compared with enzalutamide or placebo. Median survival was raised in enzalutamide study, and there was also a PSA decline. Prevail study was done in pre-chemotherapy setting in which Asymptomatic or minimally symptomatic CRPC patients were randomized to oral enzalutamide or placebo. There was 29% reduction in death, 81% reduction in risk of radiographic progression. Thus, FDA approved its label for all the patients with metastatic CRPC. Prosper study, enzalutamide was studied against placebo with non-metastatic CRPC with PSA doubling time of less than 10 months. It also showed metastasis-free survival rate and improved overall survival rate. Apalutamide, it is a pure antagonist of androgen receptor while also inhibiting AR nuclear translocation and DNA binding. It doesn't cross blood-brain barrier and thus is not associated with seizures. Spartan trial included non-metastatic CRPC patients in metastasis-free survival was selected as an endpoint. It included non-metastatic patients with PSA doubling time of less than 10 months. Apalutamide was studied against placebo and metastasis-free survival was delayed by 72%. ARV7 is a serum tumor marker in which in patients with ARV7 positive, there is lack of response to abiraterone and enzalutamide, and they show uh, better response with taxane therapies. Immunotherapy, Sipuleucel C, Prostavac BF, immune checkpoint inhibitors. Sipuleucel T is a personalized vaccine derived from autologous CD54 dendritic cells, which are first from individuals and processed with a recombinant fusion protein composed of BAP and GM-CSF. It had FDA approval in 2010 for asymptomatic and minimally symptomatic CRPC. It showed statistically significant improvement in overall survival. Largest impact was seen in pre-chemotherapy setting and early disease. It is not recommended in patients with visceral disease or in severely symptomatic metastatic CRPC. Prostavac VF incorporates a DNA plasmid containing PSA gene plus 3 other molecules. It is not a personalized product, so it is inexpensive to synthesize. Subcutaneous injections are given throughout several months. Prospect trial in which chemotherapy naive patients were or minimally symptomatic patients were allocated one of the three arms in which Prostavac VF administered alone, Prostavac VF plus GM-CSF or double placebo. However, there was no survival advantage seen in this study. Immune checkpoint blockade. CTLF, monoclonal anti-CTLF4 antibody ipilimumab is used. First trial was done in patients with metastatic CRPC who had previously received docetaxel-based chemotherapy. Superior PSA response rates were seen, improved progression-free survival was seen. However, patients without visceral disease experienced the greatest benefit. A second study was done in asymptomatic or minimally symptomatic CRPC. Overall survival was the primary endpoint. However, the study didn't show any improvement in overall survival. Pembrolizumab is an anti-PD-1 antibody. It is used for unresectable or metastatic microsatellite instability, high or mismatch repair DNA genes. 200 mg is given IV over every 3 weeks. Olaparib, it is a PARP inhibitor. 300 mg BD is the dose. It was in profound study. Olaparib 300 mg versus abiraterone or enzalutamide was used in patients with metastatic CRPC and who had progression of previous novel hormonal agents. So there are two cohorts. Cohort A comprised patients with BRCA1 or 2 or ATM mutations, and cohort 2 comprised patients with mutation of other genes. The primary endpoint was radiographic progression-free survival, which has improved in olaparib group. Overall survival was also improved. Thus, FDA approved olaparib for use in patients with metastatic CRPC, which have mutations in at least one of the 14 genes or who had previously received treatment with enzalutamide or abiraterone. Radiopharmaceuticals include beta emitters and alpha emitters. Beta emitters are strontium and alpha radium. Radium is usually used. It is an alpha emitting radiopharmaceutical. Alpha particles are approximately 7,000 times heavier than beta particles. So 1 or 2 hits are sufficient to cause cell death. They also have a very short path length. Therefore, they spare surrounding healthy bone marrow and limit hematological toxicities. Radium 223 was compared with best standard care in men with metastatic CRPC and men with symptomatic bone metastasis in absence of known visceral metastasis were included. Median survival benefit of 3.6 months was seen. 6-month delay was seen in median time to first symptomatic skeletal event. There was also significant improvement in quality of life. Palliation and CRPC, pain management, epidural cord compression management, and bone targeted treatments. Uh, Pain management for localized bone pain, pharmaceutical pain management or localized radiotherapy can be used. If patient is having diffuse bone pain, then pharmacological pain management or radiopharmaceuticals can be used. Bisphosphonates and rank ligand inhibitors can also be used. Epidural metastasis, if patient has epidural metastasis and cord compression, high dose corticosteroids can be used or surgical decompression should be used. Bone targeted approaches include bisphosphonates, rank inhibitors, and radiopharmaceuticals. Bisphosphonates include zoledronate. It reduces bone resorption by inhibiting osteoclastic activity and proliferation. Uh, in patients with progressive CRPC with bone mets, 4 mg IV dose is given within 4 weeks interval. Side effects include fatigue, myalgia, fever, anemia, and serum creatinine levels should be checked. Unusual complication includes osteonecrosis of mandible. Hypocalcemia can also be caused, therefore, it should be calcium and vitamin D should be given along. Rank ligand inhibitors include denosumab. It has shown for the prevention of skeletal related event in bone metastasis. Toxicities include hypophosphatemia, hypocalcemia, fatigue, and nausea. It doesn't require dose adjustment for renal impairment. Dose is 120 milligrams subcutaneous every 4 weeks. Lutetium 177. It is a radiopharmaceutical administered intravenously. It is indicated for PMSA positive metastatic CRPC. It is used as treatment options for patients with one or more PMSA positive lesion and or metastatic disease that is predominantly PMSA positive and with no dominant PMSA negative lesion who have been previously treated with taxane-based chemotherapy. It delivers radiation to PMSA expressing and surrounding cells, which induces DNA damage and leads to cell death. The median overall survival was seen with PMSA group compared to placebo was raised by 15.3 months versus 11 months.
Good morning, everybody. So welcome again to the teaching class. And so all the residents and faculty who have any question or comments to make, please do it after I briefly summarize the whole thing. And I also request the viewers who might have joined us today to give a thumbs up if they want to make any comment. So castrate-resistant prostate cancer, we are discussing a lot of prostate cancer because this is important in terms of your examination also and clinical practice also. And there are a lot of advances also in last few years in the treatment of prostate cancer, particularly metastatic. So this castrate-resistant prostate cancer, the word came in the year, this was devised by Prostate Working Group in the year 2008. Before that, we used to say hormone-sensitive or hormone-resistant prostate cancer, right? So this was not a kind of a correct terminology, and this was changed to castrate. So defining castrate-resistant prostate cancer, we all know, it will be defined when a patient progresses either clinically or radiologically or by biochemically, despite castrate level of the serum testosterone. So when we talk about serum testosterone, there are 2-3 important points to be mentioned about how you measure the serum testosterone level. The way we measure the serum testosterone may not be foolproof. So sometimes doing a free testosterone level or a bioavailable calculated testosterone level is a better approach. We all know this can be measured by a Vermeulen calculator, which is already available on your net, right? So there you can calculate the calculated free testosterone or bioavailable testosterone, which is a better way to measure the testosterone level. Secondly, besides serum testosterone, a serum LH level is also very important. Usually it is in the patients who have medical castration, the serum LH level will reduce drastically. It usually goes below 1. And usually the optimum LH level is 0.12. This can also differentiate whether you have done a medical castration or a surgical castration. If you have done a surgical castration, the LH level will not go down, right? So it will remain normal or high. So this is the way that you can actually monitor these patients better in a better way. And we all know that radiologically, if there are 2 or more bone metastasis or visceral metastasis, or even if the size of the metastasis increases by more than 20%, the maximum length, that also is considered as progression. Then the other thing is the pathophysiology. How does the castrate resistance develop? It develops because of some reasons. One is the intratumoral testosterone level, which remains high even after androgen deprivation. So that is responsible for developing castrate resistance. Secondly, there is a androgen receptor upgradation. And then there is an androgen receptor mutation, gene mutation, the TP53. And these are all responsible for castrate resistance. And lastly, there are cell lines, right, in prostate tissue. One is a stem cell line, one is a androgen sensitive cell line, and the other is a partially resistant androgen sensitive. So those stem cell line and the androgen partially resistant are responsible for developing castrate resistance. So once you know that there is a castrate resistance, then there are 2 types of CRPC. One is M0 CRPC and one is M1 CRPC. M0 CRPC will develop when you have given a local definitive therapy in a localized prostate cancer and patient develops a recurrence. And the patient is put on androgen deprivation therapy. And even after ADT, there is progression of the disease. And M1 is metastatic prostate cancer. When developed castrate resistance, then this is M1 CRPC. Investigations. Once you find a patient of CRPC, you should do all blood tests, including serum PSA, liver function test, ALP, and particularly it's a PSA doubling time which is more important, not the PSA velocity. So we all know PSA doubling time, if it is less than 10 months, then the prognosis is worse. So in these patients particularly, when there is a M0 CRPC, you have to continue with some kind of secondary hormonal therapy in the form of NHA, or that is novel hormonal agents, or ARPI, that is androgen receptor pathway inhibitors. And those patients who have more than 10 months PSA doubling time, particularly in M0 CRPC, they can be observed and monitored. People have, even if the patient is asymptomatic and there is a low volume metastasis and the PSA doubling time is more than 10 months, even M1 CRPC can be monitored. So once you have a M0 CRPC, then you usually continue with the other secondary hormonal therapy that includes abiraterone, enzalutamide, epilutamide, darolutamide. And M1 prostate cancer, the therapy is usually sequential. And we can give secondary hormonal therapy in the form of ARPIs, that is androgen receptor pathway inhibitors, chemotherapy, immunotherapy, radionuclide agents. So all the and chemotherapy and all these agents can be either given sequentially, and it will depend upon the prior therapy in patients who have been treated with castrate-sensitive metastatic prostate cancer. So if the patient has already been only on monotherapy, ADT, we usually will give a new ARPI, the form of either abiraterone or darolutamide or enzalutamide. And this will depend upon the patient's tumor burden, symptoms of the disease, the toxicity these drugs cause, and the prior therapy in metastatic prostate cancer. So a patient who has already been given docetaxel, then we need to start with the secondary hormonal therapy. And there are patients who have already been put on triple therapy in metastatic CSPC, castrate-sensitive prostate cancer. In that case, the next investigation, very important, is the genetic testing. And we also should do metastatic. The recommendation has been to biopsy the metastasis also, which can also change the line of treatment. Right? So doing a biopsy of the metastasis and germline testing, both somatic and the germline. So somatic testing, the tissue can tell you whether there is an MS1 or MMR deficient, right? MS1 is microsatellite instability, and deficient mismatch repair. This will act as a biomarker for giving immunotherapy in the form of pembrolizumab. And if the patient has a germline testing, which shows the different HRR, right? Homologous recombinant repair deficient, in the form of various germline mutations, BRCA1, BRCA2, ATM, CHEK. All these will help you to choose the therapy of targeted therapy in the form of PARP inhibitor, like olaparib or rucaparib. Patients who have tumor mutational burden, which is more than 10, immunotherapy, again, is the treatment of choice in the form of pembrolizumab. Patients who have very poorly differentiated malignancy, or they have a neuroendocrine variety, there the treatment of choice would be giving a chemotherapy. Or you have lost all the other kind of, your last option could be a chemotherapy. So chemotherapy is either platinum or taxane-based therapy. Cisplatin can be used, particularly in these patients. And usually these patients have a low serum PSA with symptomatic high volume metastatic disease or the neuroendocrine variety. Another marker which is important is the ARV7, the splice variant. If they are positive, then they are often resistant to the ARPIs, that is, enzalutamide and abiraterone. In that case, you have to give either chemotherapy or immunotherapy. So all these patients have to be monitored by the serum PSA, the PSA doubling time, the symptoms of the disease, and imaging. Imaging, we all know, that could be either the conventional imaging in the form of CT abdomen pelvis and CT chest and bone scan, or it could be the next generation imaging in the form of PSMA PET CT or whole body MRI. Another form of therapy is the radionuclide agents. So usually these patients who have PSMA avid lesions with bone metastasis, they can be treated with 177 lutetium, that is called theranostics. Or the patients who are asymptomatic with low volume metastatic disease, they can be treated with the other radionuclide agents like radium-223 or strontium or samarium. He has mentioned already about the alpha emitters, which are radium-223, and beta emitters are samarium and strontium. And then there is another monitoring which can be done by CTC, that is circulating tumor cells. Usually it can also tell you the response of the treatment. If the CTC starts decreasing, that means that the patient is responding to the treatment. And if the CTC is very high, even after treatment, that means the patient is resistant to all kinds of therapies and the prognosis is very poor. I think this was in summary about the castrate-resistant prostate cancer. Anybody has any comment to make? Manoj, you want to say? Anybody has anything to say? So we will start with the MCQs. So the first question, the term castrate-resistant prostate cancer has replaced the older classification of hormone-resistant disease. So again, when was it done? By working group. All right. Used to define all patients who demonstrate evidence of disease progression after initial androgen deprivation treatment, because androgen deprivation treatment focusing on medical surgical castration is the initial systemic approach for patients with metastatic prostate cancer. In patients with castrate-resistant disease, responses to subsequent AR-targeted treatments continue to show a benefit. Current data indicate that AR continues to play a major role in the control of prostate cancer growth, even when serum levels of testosterone are in the castrate range. Castration resistance doesn't equal hormone resistance. All of the above adequately describe the castrate-resistant state. Yes? So I think all of the above? All of them, because castrate resistance is not equal hormone resistance. As I said, it's a kind of a misnomer. And the rest of the things are also true for castrate resistance. One important thing is whenever you are doing a sequential therapy in these patients, never stop the ADT. ADT has to be continued, right? Patients eventually stop benefiting from primary and secondary hormonal treatments and become refractory. Which of the following statements incorrectly defines the castrate resistance paradigm? Careful clinical monitoring of patients in clinical practice, including regular physical exam, sequential assessments of radiological parameters, and serum PSA level, facilitates early identification of patients who are becoming resistant to secondary hormonal manipulation. The definition of CRPC is based on well-defined clinical and pathological criteria such as Gleason score and extent of disease. Determination of castrate resistance requires clinical evidence of PSA or disease progression to primary and secondary hormonal manipulations. The vast majority of patients treated with endocrine manipulations will develop evidence of disease progression and eventually require chemotherapy. So incorrectly, B, what is that? B, because it doesn't depend upon the Gleason score and the extent of disease, right? After initial gonadal suppression, AR signaling is upregulated in castrate-resistant disease and continues to play a major role in tumor growth. Which of the following adequately describes the AR-targeted treatment? CYP17 inhibitors target androgen synthesis, both of adrenal and intracrine source, and yield significant benefit in patients treated with first-line gonadal suppression who subsequently develop evidence of disease progression. The side effects with abiraterone acetate include a mineralocorticoid excess, state efficiently prevented by concomitant administration of prednisolone, fatigue, abnormal liver function test, possible cardiac toxicity, and potential drug interactions. So the main important side effects being, which is tackled by prednisolone, are hypokalemia and fluid overload, hypervolemia. So that is being tackled by giving prednisolone. Enzalutamide is a non-steroidal anti-androgen that differs from the first generation compounds based on a greater AR affinity, AR nuclear translocation, and DNA binding. Most patients with castration-resistant disease benefit from treatment, which was shown to be significantly superior to placebo in prospective randomized trials. The benefits from CYP17 inhibitors, that is abiraterone, and AR antagonist enzalutamide, are most likely pronounced in patients who have not received prior docetaxel treatment. All the above are correct? Yes, all the above are correct, right? Most of these are correct. Again, one important thing is usually giving enzalutamide and abiraterone together will not work, right? Because they develop a cross resistance. And so never, you don't have to give combined enzalutamide and abiraterone. Which of the following statement is correct regarding patients with widely metastatic prostate cancer who present with back pain? Administration of narcotic analgesics is the appropriate management, and if pain management becomes more challenging, the patient should be referred to hospital. All patients with known bone mets should be carefully assessed clinically for the possibility of epidural cord or nerve root compression. Administration of high-dose dexamethasone early MRI should be used, and more definitive treatment with radiation or neurosurgical decompression should be considered. Patients with back pain and stable skeletal radiographs should be treated with narcotic analgesics and corticosteroids. If improvements occur, no further evaluation is necessary. If the PSA is not rising and the workup with a bone scan and CT scan reveals stable disease, it can be assumed that the cord compression or the complex neurological involvement is unlikely. Most current systemic treatments are effective for managing extensive bone metastasis, even if there's evidence of nerve root or cord compression. So they are asking which of the following is correct regarding patients with widely metastatic present with back pain. Huh? B is correct. The rest of them are not correct. C is definitely not correct. If the PSA is not rising, the workup with the bone will stable, it can be assumed that the cord compression. So B. So B is correct. The rest of them are incorrect. All patients with known bone mets should be carefully assessed clinically for the possibility of epidural cord or nerve root compression. So all these patients present with what? Neurological symptoms, signs, right? They may present with weakness in the lower limbs, paralysis or paresis, right? So it is important to immediately put these patients on. If they have not been already put on ADT, give them LHRH antagonist or do a surgical orchidectomy. And the immediate would be a high dose steroid, and sometimes we give ketoconazole also. And then if there is an impending fracture or a cord compression, then a neurosurgical management is important. Sipuleucel 2 was a dendritic vaccine, we all know, is a personalized vaccine derived from autologous dendritic cells, the major class of antigen-presenting cells, which are apheresed from individuals and processed with a recombinant fusion protein made of prostatic acid phosphatase and GM-CSF. Which statement is true regarding the treatment? Sipuleucel T is approved for all patients with CRPC as long as they are symptomatic. No. Sipuleucel treatment results in PSA declines and prolongation of progression, but no survival improvements. Again, no. Sipuleucel T should be offered to patients with no evidence of metastasis as long as their disease is castrate resistant. Again, no. Simplicity is a treatment option for patients with minimally or asymptomatic metastatic prostate cancer. Treatment is generally very safe. There is no evidence that simplicity treatment causes symptomatic relief, any clinically meaningful PSA decline, or delay in disease progression. The drug was approved based on survival benefit compared with placebo. I think D is correct. D is correct, right? So asymptomatic patients with bone metastasis can be given this vaccine, those who are not probably fit for the other kind of therapies. Again, another important aspect in choosing the sequential therapy is the toxicity related to the drugs, like abiraterone. Abiraterone causes more of hepatotoxicity and some cardiac also. Similarly, enzalutamide would cause more of cognitive issues. So we have to know the various toxicities of the various drugs while choosing the therapy. After initial gonadal suppression, AR signaling is upregulated in CRPC and continues to play a major role in tumor growth. Which of the following statement describes AR targeted treatment? हो गया ना already? नहीं हुआ. CYP17 inhibitors target androgen synthesis both of adrenal and intracrine source and aid significant benefit in patients treated with first-line gonadal suppression. I think this was given as a first question, and all of the above are correct, right? So all of the above are correct. Right, thank you. So anybody has any comment to make? Any faculty or resident? If none of you has any question or comment, then we will wind up the session. Thank you very much. Have a good day.